We now leave schizophrenia and turn our attention to the second of the major categories in the DSM-4, Axis 1. I want to focus on the mood disorders. We're going to talk about the mood disorders in detail, but first I'd like to begin by focusing on this simple 2x2 table you see before you. This 2x2 table is a definition table to tell you what we mean by the 4 common mood disorders. We're going to define these mood disorders based on whether the mood state is mild or severe and whether the expressed mood is stable or alternating. The boundary between mild and severe is easy. Should they be hospitalized? Then they're severe. Don't need to be hospitalized? Then they're mild. And the differentiation between stable and alternating is even easier. If they have a continual mood state across time, that's stable. If they swing back and forth, and the swings are between depression on the low end and some kind of mania on the high end, well then we have the alternating. And so we have dysthymia, mild depression, unipolar disorder, severe hospitalization required depression. We have cyclothymia, which is mild bipolar, and then we have bipolar, which is severe hospitalization required bipolar disorder. In order to give these diagnoses, let me tell you at the outset here, time frame actually matters. You're not allowed to give a diagnosis of either dysthymia or cyclothymia unless patients have had the symptoms at least 2 years. The issue here is patients are functioning at a suboptimal level on a chronic basis, at least 2 years. The time criterion for severe, unipolar, bipolar is different, at least 2 weeks. Please notice, if you are so depressed, you can't get out of bed, can't do anything, nothing's fun, you're crying, you can't really even get up and feed yourself, and you're like that way for a full week, you don't match criterion for unipolar disorder. It's a disorder when it doesn't go away. The message is everybody gets depressed, sometimes quite depressed. We call it a disorder when it doesn't resolve itself by itself. Let's now talk through these different mood disorders, starting with dysthymia. Dysthymia is non-psychotic depression, mild depression, to use old Freudian terms, neurotic depression. The person has depressed mood. Now look, when I say depressed mood, don't think black, think gray. The problem with depression is the patient doesn't feel bad, they feel empty. They feel a void, a lack of something. A depressed person once said to me, if I would just feel pain, that would at least be something that I was feeling. There's a loss of interest in activities. There's no real pleasure in engaging in activities. And again, to emphasize, chronic, at least 2 years. Not severe enough for hospitalization. If you're that severe, you're not dysthymic any longer, you've crossed the threshold into unipolar disorder. I have to tell you one of the most obvious reasons why we have dysthymia as a diagnosis. This is what is written very often when people go for outpatient psychotherapy. When you tell people they're mildly depressed, they don't get upset with you like they do if you tell them certain other diagnoses. Someone who's dysthymic might either eat a lot or might stop eating altogether. They may sleep a lot or they may not sleep very much at all. Fatigue is the most common initial complaint. They come in to see the doctor saying, I don't know what's wrong, I'm just tired all the time, I've been this way for years, I don't know what's going on, I thought I should come get checked out. Decreased self-esteem and doubt about what you can do, even in basic things in life. And a sense of hopelessness. Why? Because it's not going away. At least 2 years. You begin to think that this is the way life has to be, and there's nothing you can do to change it anymore. Your ability to concentrate is lower. You can still focus sporadically, but long-term concentration is very difficult. The idea here is, again, the patient is functional, but suboptimal level. To use a metaphor of school grading, if this person should be getting A's in school, they're now getting B minuses. They're still all right. They're not in danger of flunking out, but they're certainly not fulfilling what should be their potential. Cyclothymia. Cyclothymia is a moderate vacillation back and forth between a mild or moderate depression and a mild or moderate mania. You have to go back and forth, and the way we distinguish between cyclothymia and bipolar is not by periodicity, it's by amplitude. For bipolar, you're going way up to mania, way down to depressed. For cyclothymia, you're not going quite as far up and not going quite as far down. This has to be, of course, chronic, at least 2 years, and it's egosyntonic. And remember, we talked about that term previously. Someone who's cyclothymic, they think they're fine. They think it's okay. It's people around them that think they have a problem. Lifetime prevalence is less than 1%. Unless you specialize in this area, you're unlikely to meet someone who's cyclothymic. Okay, some of our Kaplan faculty is cyclothymic, but other than that, you're not likely to meet unipolar disorder. This is severe depression, what we used to call major depression. Symptoms must be true for at least 2 weeks. And for that 2-week period, the person is, grossly dysfunctional. There's anhedonia. Anhedonia means you can't experience pleasure, and actually it's worse than that. You can't even imagine what pleasure would be. You can't even conceptualize what pleasure is. There's a lack of motivation. People with severe depression may sit in a chair for 8 hours without moving. Not because they're catatonic, they can move whenever they want to, they just don't see a reason to move. There's no motive to get them up and moving. They feel worthless. There's not just a doubt about self, there's an utter conviction that you're worthless, no good, not going to amount to anything. Decreased ability to concentrate even in basic things. Weight goes usually way up or way down. Both extremes are seen. And you have, here's that phrase again, depressed mood. Reminding you, it doesn't mean you feel sad, it means you feel empty. There's a sense of a void, an emptiness that defines depression. Also can be accompanied by recurrent thoughts, ideas that keep coming up in your head, you can't get rid of them. Now be careful, because if all I told you is someone kept thinking about something over and over again, that might trigger in your mind the idea this is an obsession. But if you see that in the context of all these other symptoms, it's not obsessive compulsive anxiety disorder, it's simply another symptom for unipolar disorder. Patients sleep either hardly at all, great difficulty, or they might sleep a lot, maybe 13, 14, 15 hours a day. They might have agitation, unable to sit still, or the opposite, retardation, being very still for long periods of time. You'll notice, I want to pause and point out, that the symptoms of depression tend to be on the extremes, one end or the other. You can't just look at one side of the spectrum. Somatic complaints are very common. Patients that are depressed often have pains, often have aches, and that's often why they might first come to see a physician. Now, knowledge about what is depression is expanding the general population, so people are more likely to come in now and say, I think I'm depressed, but it used to be they'd come in and say, my back hurts, my stomach hurts, my head hurts, and you're supposed to be able to see the underlying depression, not just to be blinded by the presenting symptoms. In severe forms, they can even have delusions and hallucinations. But these must be mood congruent, consistent with an underlying mood. If I am convinced that my insides are dissolving into my abdomen, that would be a mood congruent delusion. I'm literally falling apart mentally, so I feel like I'm falling apart physically. And absolutely, positively, loss of sex drive. Folks, depressed people, sex isn't even on the radar screen. You're sitting with a patient. You've just written a note to yourself that maybe they're depressed. At this point, your very attractive secretary walks down the hall, and the door being opened, the patient leans out to watch her as she walks by. Cross off depression. If they're thinking about sex, depression is not an available diagnosis. Whenever we talk about depression, and I ask people what symptoms I'm looking for, suicidal ideation is one of the first ones I hear back, but please notice, although I do want you to associate suicidal ideation with depression, 60% of depressed people have the ideation, 40% do not. You can't wait for that to make the diagnosis, or you're going to miss 40% of the cases. 15% of depressed patients do die by suicide. This, along with alcoholism, schizophrenia, and borderline personality disorder, is one of the big 4 diagnoses associated with suicide. Biological correlates. PET scans of the heads of and the workings of the brains of depressed people show really high glucose metabolism in the amygdala. Now, that makes sense to me because you have a mood disorder, and that means you're going to have mood swamping out cognition. That means excess amygdala activity swamping out cognitive organization. Correspondingly, we find therefore smaller hippocampus and atrophy that sets in increasingly over time. Once again, affect swamping out cognition. The amygdala takes over and starts to push aside the cognitive organization from the hippocampus. Depressed people have abnormally high levels of glucocorticoids. They have an ongoing stress reaction. Some people suggested the numbness is just that. They're always in that state of stress alert, and so they can't respond differentially to changing circumstances and environment. Neurochemistry is easy. Everything goes down. We have lower norepinephrine, lower serotonin, lower dopamine. Importantly for the exam, the metabolites of these will also be decreased, a more likely exam issue. Sleep correlates we've already talked about before. Let me just review again quickly. We find increased REM time, decreased REM latency, maybe much quicker, 40 minutes instead of the 90 we expect, decrease, even disappearance of delta sleep in severe cases, increased REM time overall, early morning waking, and you might get a lot more sleep in multiple periods across 24 hours. The last of our set is bipolar disorder, what we used to call manic depression. Please note we don't use that diagnosis anymore. The label, correct label, is bipolar disorder. In order to receive a diagnosis of bipolar disorder, you must have symptoms of some level of depression along with mania. Please notice there is no diagnosis of mania by itself. If you see someone who's manic, they're bipolar. If all you've seen is manic, you just haven't seen the depressive component yet. Mania is a period of abnormal, persistent, elevated mood. The person is up. They're up, they're active, and this goes on for a noticeable extent of time. They must alternate back and forth between mania and depression. There's not just mania, there also will be depression someplace. Let's distinguish between three subtypes of bipolar disorder. The most common is bipolar 1, with a lot of mania and then a little bit of depression. Then we have bipolar 2, which has a lot of depression with a little bit of mania. Should be easy to remember because bipolar, you should be thinking about mostly mania, and that's bipolar 1. Bipolar 2, secondarily, that's when we have depression with just a little mania. But I also want you to focus on rapidly cycling bipolar disorder. This is a difficult one to cope with. The person whipsaws back and forth within a 2 to 3 day period between depression and mania, depression and mania. That's very difficult for people around them to cope with, and we use a little bit different pharmacology in treating that. How do you know somebody's manic? Oh, goodness. Great grandiosity, tremendous self-esteem, a conviction they can do or accomplish anything, yet low frustration tolerance. They have simple barriers in their way. They don't bear down and solve the problem. They spin off an entirely new direction. Decreased need for sleep. Boy, when somebody's manic, they're going to sleep as little as possible. They're not going to wake up and roll over and go back to sleep. They wake up, they're up. There's something to do. There's too much time. Let's not waste it. Let's go. They're always trying to be in motion. There's a flight of ideas. I feel like the ideas are coming so thick and fast, like you're missing them. They're getting away from me. Somebody once described it to me as like bullets whizzing by, and you need to reach up and grab down those ideas before they go away. Excessive involvement activities. They volunteer for everything. They think they can do anything. Weight loss and anorexia almost certainly, and understand why. It's not because they don't want food. They're too busy. They're too preoccupied. They don't have anorexia nervosa. They simply are too busy doing other things. They forget to eat, and so you have the obvious thinness that sets in. Behavior is erratic, uninhibited, and they have an increased libido. They love sex. An important clinical issue. One of the reasons why it's hard to keep bipolar people on the medication is right here. They have a lot more sexual activity when they're manic. When you give them the medication, you take away the manic phase, they don't really have the same sexual prowess. When you talk to bipolar people, what they really want is, leave me the mania, take away the depression. But we can't do that, of course. To reduce the depression, we also take away the mania. Neurochemistry should be predictable. We find increases in norepinephrine and increases in serotonin. Please note, though, not increased dopamine. Why? Well, if we had increased dopamine, the patient would be schizophrenic or at least schizoaffective. Sleep correlates, multiple awakenings, decreased need for sleep overall. They're sleeping when they have to biologically, but as little as possible usually. The key exam issue is when you're reading through the question, you're going to have to decide whether this patient presented is unipolar or bipolar. So this table is geared to help you with that process. Okay, first, unipolar is much more common. Up to 3% of men have unipolar disorder at a given point in time, just under 10% of women. Notice that just 1 out of every 10 women has unipolar at a given point of time. For bipolar, less than 1% for either gender. For unipolar, women twice as likely as men to have unipolar. For bipolar, the rates of gender are effectively equal. Lifetime prevalence. Up to 10% of men have unipolar disorder over the course of a lifetime, and 20% of women. Again, focus on that. 1 in every 20 women will have a hospitalizable depression. For bipolar, 1% for either gender. Where else have we heard that 1% figure? For schizophrenia, right? And here's a rule of thumb. Doesn't always work, but it's a pretty good rule of thumb. Whenever you hear 1%, think genetics. You're going to see that works here. Age of onset of unipolar is somewhat older, about age 40. Age of onset for bipolar, age 30 or sometimes even younger. Neither of these are exclusive to high or low SES, but we're more likely to find unipolar in low SES and more likely to find bipolar in high SES. Relationship issues. Unipolar much more prevalent among people with no close relationships, people who have been separated or divorced. Bipolar, much more likely that people are single or divorced. Why? Come on, would you like to live with this bipolar person? And if you found yourself married to them, you're unlikely to stay married to them. Yes, there are some people that are bipolar and married, but they are the exception that proves the rule. Bipolar people are usually very difficult to live with. Family history. If you have a parent who's depressed or alcoholic, please note both are risk factors, or if you lost a parent, some sort of accident or maybe a divorce prior to age 11, chance of unipolar is much greater. The only risk we have for bipolar is your parents are bipolar. Notice if your parents are alcoholic, there's no risk for bipolar. Notice if you lost a parent early, there's no risk for bipolar. The only risk for bipolar is parental history. Let's talk about